welcome back to another episode. How are you today, Renee?
Hey, I'm doing great. How are you?
I'm fantastic. Oh, it's the middle of winter, and you know how much I love being in the middle of winter. Worried about fall already,
Oh boy.
trying to figure out some different drying variations and maybe a new grain bin. But you would think in the middle of winter, I could get some quotes and some design elements and figure this all out. It's very frustrating.
Wow. It's funny to me that you're already worried about fall and we're still not even got stuff planted yet, but that seems okay, I guess.
Welcome to the world of a farmer. That's what we do.
Talk about the cart before the horse. But all
Yep.
right, I'm excited for you. That's fantastic. So, Jason, today we're going to talk about one of your favorite topics. And I know this because I've probably listened to, I don't know, a dozen or so rants on the topic. But today we're going to talk about when is a mental health bed not a bed? And for those that are out there listening, thinking, well, that doesn't make any sense at all. Why would you even be talking about that? A bed is a bed is a bed, one would think. But the work that we do day in and day out, we have figured out that people call lots of things a lot of things, and there's lots of what we call stars on a map. But that doesn't actually equate for places for people to put their head at night to get treatment. They're not the same. And today we're going to dive into that more, some of the data about what we're looking at in our state and some of the states around us about, beds, how many we should have, and then talk about like some stories, because boy, do we have stories in this space. This is sort of the nexus of what we do. So, Jason, kick us off. When is a bed not a bed?
Well, I blame you for this, Renee, because I never knew all of the issues. I always knew there were issues with beds, but still we started doing work around the Midwest of just how many different definitions exist for a bed and how frequently we count, double count, and triple count
Mm,
beds,
mm,
depending on who's asking the question and how we want to make sure we're in compliance with some external body, whether it be a federal level type audit, statewide audit, an accreditation count. We all define the same bed slightly differently. And so it really makes my head spin when I
yeah.
get out there and we're trying to differentiate, because frequently we're called literally to count beds. That's been a lot of projects that we have has been help us understand beds. And where do we start when we start to unpeel that onion, Renee?
Well, it always sort of starts with the legislature in many states, and they're getting complaints that there's not enough places for their people to go. And that's legit. There's legit issues with people can't find the right placement, the right level of care for the right person at the right time kind of situation, which is the goal of what we're trying to do here. And that's a legit concern. But the very first request always is maybe we need more beds. And it doesn't matter what state, what size of state, what place we are, everybody wants more beds. And that is the number one request. I think we need more. Kind of like your grain bins, I think. We just need more. Makes me laugh. But you start thinking about that. And then when we dive into it, sometimes it's not, maybe sometimes they do legitimately need more. We haven't really found that to be true, but sometimes maybe that could be. But instead, it gets to be like the definition, like what is it? Where is it? What's it used for? Who has access to it? I know we have a lot of stories today, but before I forget one of my all-time favorites, do you remember? I'm not going to name the state, but the state was counting beds that were in the prison and you actually had to be incarcerated to access them, but they were counted in their count as numbers of beds for the public. Do you remember
They
that one?
they were actually counted as substance abuse treatment beds, believe it or not.
Yes.
And so
Yes.
it looked like this particular area
Yes.
had a whole bunch of substance use treatment beds. And
Yes.
I thought it's great. Um,
Amazing.
they must be doing amazing work around addiction and getting
Amazing.
ahead of addiction. And there was a huge opioid epidemic in this particular state. And we're like, this is fantastic until we realized none of the beds were accessible to anyone who wasn't incarcerated. And then I had to question, why are someone incarcerated need a high level of substance use treatment? Because one of the main criteria would be having access to the substance. And I wouldn't think if you're in a secure environment, you would have access to those substances. Would you, Renee?
There's some challenges with this. Having worked in the system here myself, we can get hooch. Hooch would be made from fermented fruits from the
No.
cafeteria. They make their own. And then sometimes we get K2 stuck through like on stamps or letters or things sent into the system. Opioids are much more of a challenge unless people are cheeking them and selling them within. Also could happen. But to your point, generally speaking, people should not qualify for the high level of residential substance use beds while incarcerated. Those should not be the same thing. But I know I got ahead of myself, but that is one of my more favorite stories because how do you even access this, right? It's like on a document as if it's public access for substance use, and you had to be incarcerated to even get there. I mean, just blows my mind. But let's start with the definition of a bed. So both the American Hospital Association and the World Health Organization defines a bed count as the number of beds that are regularly maintained, that are set up and staffed for use for inpatients at the close of a reporting period. So numbers right there tell you that they fluctuate because they have to not only exist physically, but they have to be staffed. So that is a fluctuating number on any given day. And that is a source at the beginning of a problem. And this is talking about inpatient beds. So this includes medical, it includes psychiatric, it includes all medical beds. So a bed is not a bed just because it's sitting there. You have to be able to staff it. And so then the second definition adds another layer of complexity here because the American Psychiatric Association acknowledges that the bed can be used for two things. It can be used for both medical and psychiatric. And this is where those issues begin, all the way at that baseline of just inpatient beds, because they have to not only be a physical location, but it has to be staffed. And then it can swing. It can be used sometimes medically, sometimes psychiatrically in some hospitals. And then that changes your number any given day. There's not a stable number of this many psychiatric beds because it can be used for medical. And I don't think the public understands that that's the basis of the entire system. So when you're already starting on a shifting foundation, it should be no surprise that naming beds and knowing how many you have is a lot harder than it sounds, because just even that level is challenging. But
Let
what
me
else are we
throw
seeing?
one more wrinkle into that, Renee, and that's oftentimes we don't even know where to start with an inpatient level of care because now we have levels of care like subacute that may not occur in a hospital-based setting.
That's right.
Same with detox that
That's
can
right.
occur in a free-based setting organizationally, right? If they have the appropriate medical staff. And so a lot of times with legislators, and I can speak directly to 3 states, I've had conversations with legislators at this point where they don't even know what inpatient means, right?
Nope.
They're like, are you talking about residential? Are you talking about inpatient? Are you talking about subacute? Are you talking about crisis residential? Like, where do these things fit in? I was just watching some legislative committee meetings for a state that we're going to start doing work in that we just got contracted for, and that was the question the legislators were speaking about in the last meeting was, does this study include the residential beds? And they're like, we're not sure. That's how it was left. So I'm looking forward to this project, Renee.
Well,
um
remember one of the states we worked in before, it started including nursing home beds.
right.
And so it wasn't even just, so you start talking about what types of beds are out there. And on the mental health spectrum, the highest level is inpatient. The next highest would be a subacute. And then you would have either a residential or crisis stabilization. Crisis stabilization should be a little bit higher level of need, but shorter term, where residential is more longer term. And then you can have kind of a transitional housing kind of level, but it's not really a mental health bed per se, but people that need long-term assistance and stable housing could use it. And those are really the mental health side, and that's a lot. But then if you start adding into your point, your medical beds, so you could have your inpatient beds or your ICU beds, and then you start adding nursing home beds or assisted living or, skilled nursing and all the different levels of that. It just can be really unbelievable, the
do you,
number of things that
do
are
you
out
remember
there.
geropsych? So we
Oh
also
boy.
have geropsych beds, which I assumed meant older individuals who are having some cognitive mental health condition issues. And
That's
what
what
we
it sounds
found,
like.
it's what
Sounds
it
like.
sounds like, because
Sounds like.
geropsych would be geriatric in my mind,
Geriatric.
per definition. And we found that most people who are in these types of beds were under age 40,
Yeah.
which was just
Yeah.
fascinating to me.
Mind blowing.
In
And
nursing homes, in nursing home
in
settings.
nursing homes. And on top of that, you find out that that level of care isn't even defined in their law or their rules. It was just contracted into being. And it definitely wasn't necessarily legal on lots of different levels. And the fact that it existed was shocking. And when you go and say, okay, well, what are the requirements or what's in the code or the law? See, I'm one of those nerdy policy people that I always go back to, well, what does the law say? Right? It's like, okay, this thing exists. called geropsych. So what should it be? So that you have, guidelines of how you should do it, how many beds there should be, blah, blah, blah. Not one thing written down. They 100% built it in a contract form and had no rules written at all. So you can imagine when they had trouble duplicating it across a state or making it work in some sort of a consistent way, because there was nothing consistent about it. There was no foundation of policy or rules or anything else to build upon. And the fact that they hadn't been in trouble was really kind of interesting to me, because in other places that could have been a big, big problem. And so, yeah, talking about beds. So Jason, when we started this conversation, there are some data here, but the interesting thing about data on beds, tell us your favorite part about data when it comes to beds.
Well, I don't even know where my favorite part about data comes in, because it's also fascinating. I'm glad you said data, right? Because we should be able to find solutions when we're able to gather appropriate data and make decisions based upon data. Of course, the data has to be measuring the right things, right? And we
Yes.
need to go to your point of we need to go back to rule, regulation, and we need to have clear and specific definition so we understand levels of care. And really, we need to understand if there is a continuum of care that's clearly defined, because that's what the system should look like, right? We should be able to move through a continuum of care, stepping up and stepping down based upon the needs of the patient and the level of care, right? That we should only provide the least amount of care someone needs. So they should have freedoms, right? We shouldn't have someone in a locked inpatient facility if they can manage just fine in a subacute type setting, right? Or lesser level of care based upon their needs. And so I kind of love it. So a lot of states went to bed trackers, right? It was
Oh.
supposed to solve the world because we would track how we were using the beds, or we would know how many
Mhm.
beds are available across the state or across the system. And so we've been in a couple of states where the answer was we're going to put $5 million toward a bed tracker.
Mhm.
And what have we found when we go back and we ask questions about those bed trackers, Renee?
It didn't work.
It didn't work at all. Why don't bed trackers work when they're not taken into consideration with the continuum of care?
Well, there's a lot of reasons bed trackers don't work, and I can go into some detail here for a second. But one, people are not linear. Mental health is not linear. So there was one proposal on the table once to make beds, say, level A, level B, level C, where you had so many beds at this level A, which was a certain type of criteria for certain types of diagnoses, maybe, or a highest level of acuity or something, and then a group of B, group of C, as if you could just by population decide who's always an A, who's always a B, who's always a C. Well, people aren't a label, and their diagnoses are not a label. And last I checked, unless somebody's very, very dialed in on their medication, and that's pretty rare, is mental health a straight line? It fluctuates with lots of reasons, right? It could be time of day, time of the year. We talked about seasonal affective disorder. There's lots of things that change for a person. And so trying to just categorize a bed by a label and say, well, we have this many people in the state that need whatever level, so therefore we're going to have this many beds, and you have to keep so many open and not pay for them, keep so many open in case somebody needs that level of care. It just wasn't going to work. That's one. Another one is because, well, many times they haven't made it mandatory that people use the system. So people who have the beds don't necessarily have to input any information into them. So therefore, the tracker's not going to be, up to date at any given time if not everybody's participating. And then if you talk to people that are at hospitals, do you know when the most likely time to find an open bed is? Would you want to guess what time? If you had to pick first shift, second shift, or third shift, Jason, play a trivia game with you. Which shift would you bet is the most open beds for
First
placements?
shift. First shift.
It's third shift in the middle of the night. So after the hospital has held every bed open to possibly get anybody easier admitted, really late into the evenings, that's what time they will open beds and say, oh, now we can take a person. And I know that because one of our partners that we work with pretty often collects data as what time of night they can get people placed. And they can get them placed after 10 p.m. because a lot of times after that evening shift, they're like, nobody local is going to come in. So we'll take somebody from wherever and fill a bed, because if the bed stays open past midnight, they don't get paid. But if they can fill it before midnight, they can get paid. So if you look at that late shift and before midnight, If they could get somebody in at the last minute, they get paid for the day, had the least amount of time in the space, the least amount of trouble from the person, etc. And so it's subjective, and nobody wants to talk about that. But it has to do with staffed beds. That was our definition, right? And so if somebody comes in with a very high acuity level of need and you don't have the staffing to be able to pull it off, the bed's not open to that person. Is the bed open to somebody else? Maybe, but it's not to the person at the ability that it's staffed. And there's nobody in the world that wants to understand that. So those are my two or three biggest reasons why the bed tracker doesn't work. And nobody wanted to hear that. They just figured it's a number of beds and hey, we'll just assign a number to it and people will track it and like somehow like cattle and it would just work. And it doesn't. And it never was going to. And the fact that people promised it would is crazy. Somebody made a lot of money on something that was a fake promise.
And we're not saying it's not an important data point to have. It just has
No,
to be taken in along with a lot of other data points that aren't currently being tracked or aren't
that's right.
currently understood. And I think that's part of looking at the continuum, because I think there are some real issues too with people get stuck
Yeah,
in hospital beds that they shouldn't be in. And so a lot of times in the systems work that we've done, part of what we uncover is that you have people in a bed for 30 or 40 or 50 days who shouldn't even be in a bed, right? And so they're taking a bed that 10 other people could have gone into
that's
for
right.
a short-term acute care stay,
Yeah.
but that bed was being held by someone who was unable to be placed in the level of care they needed to be in, right? And so the system clogs itself up. How do we start to address that issue? Because the bed tracking system hides the system inefficiencies and ineffectiveness of moving people to the right level of care at the right time.
Well, I first of all want to say it's not just the mental health system that has this problem. I'd love to tell you it's just this, but it's not. You have your aging system of care, and you've got people that are on the continuum there that get put in the wrong level of nursing facility, or they need memory care and their stuff stuck in a skilled facility and whatever. So it's that aging level of care bed situation is wrong, and then prison and reentry is also wrong. You get people that have sex offenses. Nobody wants them anywhere, and yet they're taking up spaces and sometimes dying in your prison facilities because you do have no other options for them. And so this conversation is multifaceted and multi-leveled. It's not just mental health. I don't want people to think that, well, mental health's all screwed up and they're the only ones. It's not. It's about beds in general. And so you get the wrong people at the wrong place at the wrong time, and it could be a lot of combinations of people. And so part of it is just complexity of that, and having to have open conversations and sort of candid conversations about this. And so with my work now with re-entering folks, working with mental health, I've had those exact conversations. Now we're nowhere close to where we need to be, but starting a conversation with the Department on Aging. So if you've got folks that are sitting in prison institutions that have Lou Gehrig's disease or have full-blown dementia, who have no idea that they've committed any crime at this point, but there's no mechanism to remove them from that facility, those prison facilities are becoming de facto memory care units, de facto hospices, all the things that they're not really trained or equipped to do. And so you've got to have some conversations about, okay, where should they go so that they can get the proper health care for end of life? And what does that look like in an incarcerated situation too? And so this is a lot of different things, but it starts with those conversations, right? It's like, okay, who's responsible for this class of people? And we've done that in our state with mental health. And so in this case, it's going back and circling back with some of your key partners and saying, this group of people is your responsibility, right? And holding people to the fire, because we have access standards in our system. We have expectations of length of stay for crisis stabilization. We have lengths of stay for different things. And so holding providers accountable to helping them move them is a conversation that has to happen. And somebody sometimes has to be the bad guy and say, these are your clients, you have to serve them. And I think that's some of the work that you're doing in one of the regions that you work in, is trying to have some of those memos of understanding that, hey, these are our people. We all have to serve them to do the job. And we are all going to have to agree to work together to place some of these harder to place people. Isn't that some of the work you do?
It absolutely is, Renee. And part of it is getting people in the same room to have that
That's right.
conversation. And it shouldn't be a surprise, but it is a surprise. Every time that we get together with a room full of leaders and care coordinators, and we're like, well, how do you all communicate? And people look blankly at
Mhm.
me and say, well, we haven't communicated since the pandemic. because so and so left and now I don't know who to call. I'm like, well, how do you coordinate care then to transition patients? Well, we don't do that very effectively. Last time it ended up with an argument, and then there's these horrible stories that come out, and then people are talking through lawyers, and we're like, well, how do we get away from that? And so, we've got hospitals at the table. We've got specialty care residential providers, crisis residential providers, and other addiction providers. And we're now starting to see that just getting that communication pathway established yields better care and opens up beds because people aren't stuck at an acute care bed in a hospital when they can get to that lower level of care when people are communicating and
Yeah.
sharing clinical information, right? And so oftentimes we get stuck because we're not sharing information. We're not accurately portraying the individual. And then people are like, well, they're not being honest with me, so we're not going to take that person. Well, we've got to get
Mm.
beyond that. We've got to look at what's in the person's best interests and how do we move people through the system that we have, not the system we wish we had, because it's going to be messy sometimes. And so we've seen a lot of success as we continue to move forward, and we're going to be creating policies and procedures that all 20 of these organizations are going to adopt, because if they're going to continue to get regional funding, then they're going to have to figure out how do they work at a higher level together. And
Mhm.
then that work, we hope can move statewide. That impacts then the system, which then creates better tracking. Then we know where we have beds. Then we know where we can get people so there's the right level of care at the right time.
Yep. In the incarceration system in Iowa, I think they call it kind of a strike force. It's a task force of some kind, but basically it's a problem shooting group that they pull together, whether it's monthly or quarterly, where they have the hard to place, difficult situations, not sure what to do with, and staff them and have kind of the key people that can make decisions in those meetings. They don't have them all the time. It's not about everybody, but there's always a handful of folks that rise to the top that you have to have a little bit of extra hand holding, a little bit of extra work. And they have found that to be pretty successful. And that may end up, bringing in a department head at HHS or department heads at aging or whatever. And the region would do the same thing, right? When you get stuck with a particular person that you just need a little bit more thoughts or bringing in a third party perspective so they could see it at a different angle to maybe come up with an idea that your group hasn't seen, or pitch a new plan, a new idea. And those kind of task force are very helpful. And so if you can it's not going to be everybody at the table, but you can get the key people that need to be there and they meet. But it's to your point, communication about the problem and being candid about that problem is really important. You have to say, they're a difficult person to place because of these particular behaviors or these particular felonies or these particular issues, and have that conversation. Because if you don't mention that, right, for just an easy example, if you don't tell somebody has a felony, they may lose their lease out of their apartment. Landlords don't have to sign off. And it could be as simple as that. But because somebody tried to not mention such and such about somebody, then they just lose their housing, and which becomes a massive issue, right? And so having candid communication, that's where you start. And you have to, again, look at your laws and your rules, kind of your foundation, so that you're all playing on the same field. Because if people have interpreted those rules differently, they may be like, well, I don't have to deal with those types of people, and I don't have to do this. Well, if you're all on the same play sheet, to your point about creating standards and practices, right? You're all on the same play sheet going, these are our people, and we're not just going to dump these folks. We're going to figure this out. And it gets everybody on the same page, where you also feel then you're part of a team making those decisions, and you're not just isolated, stuck with this guy in your bed that you just can't get out of your place. And it just helps but communication, is simple as that sounds, Jason, that's the place you have to start with these conversations, because you have to be open and honest about the issue you have.
There's 4 words that have really helped us with that: no eject, no reject.
Mm.
And so putting into place where we can't, take into account someone's history, we need to take into account where they are today in the course of their illness and provide that treatment based upon that. And so we've done a lot of work around how do we define no eject, no reject across different systems, because that can be really scary for clinicians and providers to think about what that looks like. But that has really helped us to get over some of those humps, as we move forward.
Yeah. And some places, unfortunately, have used that as a weapon. One state I can recall, they had that rule in their geropsych type nursing study that, you had to take them back. And if that person assaulted all your staff, and
Mhm.
hurt people and all of that, and then you're forced to take them back because the state's not willing to engage in these tough conversations to help you find all the alternatives. That becomes a weapon. So no
Right.
eject, no reject can be a tool, but it can also be used as a weapon. And so you've got to be really careful with that, because you're supposed to be thinking about, people are all people and they deserve the help that they need. That's the piece we're talking about, not that we're using it to beat somebody over the head, that if you don't have the staff capacity to do this, but we're going to make you take this person and then injure more of your staff. That's not a good call either. So it's sort of this interesting balance, but when you talk it through, it's not near as scary. And if you're part of a team, you're not near as scary, because the no eject becomes for the whole region. We're not going to eject them as a region. Wherever they are may not be the right place within our space, but that doesn't mean we give up on the person. We keep working to try to find them the right space, but we work together as a collective to find the best spot, not it's your bed at your place and you're stuck with them kind of a message. But again, it goes back to communication and having to build that trust. And so it's hard work, it's
So,
good work, but it's what we've done in multiple states at this point, is having to come back and say often to the legislature, guess what? You don't really need new beds, but you've got some people stuck and you need to figure out how to unstick the folks that you have stuck, and then you'll have the flow through that you need to have the work that you need done. It's a different answer than often what they're expecting, but it's the way
so
it
let's
turns
talk
out.
about that approach, Renee, because it seems kind of overwhelming, right? It seems like there's so many moving parts and pieces to all of this. And so, I think our legislators often, with the best intentions, write some of these laws to try to fix problems,
Mhm.
but somehow in that implementation, things go awry. What do you have to do? I think about the work we've done, like to actually call out some of the issues. Is there any way to do it sitting behind a desk, or does it sometimes include you just got to walk out in the middle of a facility and start asking questions?
Well, I know when we were tracking beds in one particular state that it worked a lot better when we stood in the middle of the facility and said, okay, what is that bed? You have one right here, this room. Who is qualified to be in the room? Like what
I
type of level of
I
care?
remember that conversation taking almost half an hour because we had
It
a
did.
list provided to us from the state,
It did.
from licensing and three other departments. Literally, we had all of the licensing data and accreditation data from the state, which had listings of
Mm-hmm.
all of the licensed beds of
Mm-hmm.
different levels of care, right?
Mm-hmm.
Throughout the continuum.
Mm-hmm.
And so we had that list in our hand and we walked into a facility. Am I remembering this correctly?
You
And we
are.
stood there and I asked, it says here you're licensed for this. And they said yes, right? And I looked around the building and I could only see about 8 beds, like literal
Yep.
physical beds, because we were seeing the whole facility,
The
right?
whole thing.
And then I said, well, if these 8 beds are this, then how can you be licensed for these 8 beds? Oh, yeah, we have those beds too. Because I'm looking around. I'm like, well, you said you had these beds over here and these beds. I said, but what about these beds over here? Because they were also a shelter, I believe. And I go,
Yeah.
where are these beds? Oh, they're right here too. Now we're now up to almost 24 beds. And I believe there were only 8 physical beds because I actually had to walk around and count them. I put my finger on each one. I'm like, well, 1, 2, 3, 4, 5. And
Mm-hmm.
what did we learn from that experience, Renee?
That we called one bed three different things and counted it three different times. That's
So
what we
what
learned.
so how did that impact the greater system when people had an expectation that there were 3 times as many beds than what truly existed?
Not good. And one of those levels of care, if I recall correctly, was an ASIM level for residential that they had pretty much wiped out in its
Yeah.
entirety. That didn't happen at any of those facilities in any parts of the state. And they failed to mention that, but they were all still licensed for it and posted on each of their doors. We could take pictures of the actual licenses, and the service did not actually happen, period. And horrible, because the legislature, of course, doesn't know that, because again, back to the stars on the map, shows that all of these residential services were in these 8 locations, and every last one of them had been shut down. And that's a mess. And that's lack of communication. That's lack of candidness or honesty. And just bald faced lying to people who need the service, who are there. Looks like there's licensed for, if there were 8 locations, right? That's 64 beds that honestly didn't exist. And nobody owned up to that. It was like a big mystery. And when we go back to the legislature and explain that, they're like in shock and awe. that that's a thing. And we're like, we were there. It's not a thing. And they just bought it that because it was licensed for that meant therefore it was. And that's just crazy. And that happens all over the place. And so, I know in our state, we've worked really hard at getting an actual list of how many beds, specifically mental health inpatient beds, there are. And, back in 2021, it was like 700 plus of them. But if you look into 2022, I think it's down to 500 and something of them. Because I think this, right, Jason? There was a new hospital built like not too far from where I live
Hmm.
that never made over half capacity. It never ever was staffed to over
Correct.
50%. And the beds were counted originally because it was supposed to be 120 some odd bed facility. But I don't think we actually ever staffed over maybe 60 to 70 of them. So that's not 120 beds in the system. It's just not, because we go back to our original definition. It has to be a bed, but it also has to be staffed. And that wasn't really what was going on. And so I get why our listeners are so frustrated with numbers of beds, because the staffing piece is a much bigger challenge than people want to admit.
And don't assume our state leadership understands this issue. We were just contacted, we're contracting right now to go to another state and have the same conversation because they implemented a bed tracker and they still have a backup in their psychiatric system, and they don't understand where their inpatient beds are going. They don't understand why people can't move from jail to competency hearings to an inpatient bed. And so we're going to have to go in, and I'm afraid that I'm going to be walking around a state again counting beds is kind of my fear, Renee. And I know you're laughing because I'm the one taking lead on this one. So I'm gonna be literally going to a rural state and walking around and counting beds again. Because that's the only way I think we can get to the root of this. I think the legislation is going to be fairly sound of what they wanted to do. Again, it comes down to implementation. Was it implemented in a way that those systems are communicating and we can move people seamlessly from one level of care to the other? And I've already written the report in my head because I
Yeah,
already know.
the answer is no. The answer is no. Now, what will be interesting to see is if the state actually has enough beds for the population. And there are some data points out there about that, but even that's disputed. So today, we were lighter on the data portion of our talk than we normally are, because the data really depends. It depends like who you're asking, who's answering it. And I struggle with this all the time, but definitions are so, so important, right? If you call a crisis bed three different things and count it three different ways, it's just not helpful because it's one physical location where only one body can be in it. And what we find that very common, and different states call things different things. So part of what your challenge is going to be in the new state is what the heck are they calling it in the first place? Because that's always the big part, is always the mystery of, well, what do you mean when you call it that? And you say it's this level of care. And what I think is the funniest for me to watch you is when they call ASAM stuff things that are not ASAM, because ASAM is pretty directly specific about what
Right.
things are. But then you walk into a state and they call it something, and you're like, that's not what that is, because ASAM is pretty black and white. It is or it's not. And they still call it something else, like the ones we found in prison. And you're like,
Right.
no chance. There's no chance that ASAM beds are in prison. And that just makes me laugh because they throw around the term as if they know what they're talking about. And it is nothing at all defined the way it's supposed to be defined.
Well,
And so we get it confused, and this is our job and this is our expertise. And so just imagine the regular person trying to find help for their person, and they can't find help for their person because they're arguing about all of this stuff that doesn't make any difference because nobody defined what the heck we're talking about. It's just completely frustrating.
it's even harder if you live on a boundary of a state, right? If you're doing
Oh
work
man.
in one state or you have to get care in another state. Because, at the end of the day, every state's Medicaid system looks differently, right? So it's
Right.
really going to matter about what that state can fund as to what the array of services that exist in that state look like. And
Yep.
that's why we can't really shift this back to a lot of data right now, because every state is unique in how they choose to implement their Medicaid system. And we know that a majority of these types of services are ultimately funded or subsidized through Medicaid or through state block grants, or
Mhm.
other just, state line item budget items to support the infrastructure for those who need these services. And so I think that's part of our challenge as we look at these things. Renee and I have the unique background of being able to bounce around to some states and really roll around in their Medicaid systems and how they've developed and designed things. A lot of people don't get that opportunity to see that perspective and viewpoint, but it makes it kind of easier for us to step back and go, okay, we understand implementation and design, but at the end of the day, it goes back to what can be funded, because that's really then the core services that build out a state system.
Yeah. I get really sad for some of the legislators because, in their heart of hearts, they're doing the right thing. State legislators don't get paid a lot of money. It's not a thing that you just go to run for money or fortune or fame or anything like that. They're doing it to try to help people. And it's just so disheartening and so hard to watch their little faces when they figure out that a bed tracker's not going to work. And could have told you it wasn't going to work. You didn't want to hear that it didn't want to work. Somebody came in with a slick sales pitch and sold you a bill of goods. Great. And then later they're like, it didn't work. And we're like, are you ready to talk about why it doesn't work? And what, you can make it work better. Like, you have to have everybody participating, right? There's some pieces like that you can make it where you could start to level the field and try to get some better data, but you need other pieces like you're talking about, Jason. There's other parts of the data system, like staffing, workforce shortages, things of that nature that needs to come along with the bed itself. It can't be just a bed. It needs to have some other information around it to have a full picture. And so you can teach people that, but it's just so disheartening because sometimes their little hearts break because you could tell they worked so hard on it. And then it's just, yep, that's just not going to work. And so, but it's also kind of funny, I think, that you'll see something happen like that across the country. It worked in one state, or they all went to some legislative conference and heard about it in some state. So then every state wants it. Okay. And then you get to the end of it, the rainbow, and you spent a lot of money and it didn't really get you what you wanted. And so now it's like, okay, now how about let's go back to your unique challenges of your unique state and find a solution that works for you. Cookie cutter approaches don't always do the best. And so we struggle with that. Well, this week I wanted just to bring back a self-care policy. We talked last week about tracking and all the different ways you can track, but this week I want to challenge you. It's February, so maybe you should actually track a habit. Pick one. Doesn't matter which one. Maybe you thought about it last week, but pick one and actually track it and see what it does for you, because you can't say that you don't, that drinking a glass of water did this or that for you if you haven't actually drank extra glass of water a whole bunch of days in a row to see what it does for your body. And so it doesn't matter what the habit is, but I'm going to challenge you out there listening that this is a self-care tip. Pick something that you want to track and do it for a while. Now, I know out there people think that habits can be created in 21 days, and whoever said that made it up. That wasn't true. It's not even research. They show that most habits are around 66 days, and some take even longer if they're more complicated habits to instill. And so you have to try it for almost a few months. It's a couple months, 3 months, and then see if it's made a difference in your life. And if you've tried it and it doesn't work, don't do it anymore. And the easier way to think about it, if you want to start a habit, is stack it onto something you already do. So for Jason, it would be to attach it to his peppermint mocha latte, because he drinks peppermint mocha every day. And so he could do something immediately before or immediately after, because every day he's going to have a peppermint mocha. So you could start a habit and you just stack it on top of something he's already doing every day. And that's where it could begin. So if you're a person that brushes your teeth the same time every day, you drink a glass of water every day, whatever it is you do every single day that you normally do without even thinking about it, attach a habit to that and see if you can create something else and create something new. Well, today we talked about, when is a mental health bed a bed? And I know it was a complicated conversation today. And if you're frustrated out there because you can't find the bed that you need and the place that you need, don't worry. Everybody's frustrated about this subject, partly because we don't agree on definitions. We double and triple count some things sometimes, but we don't mean to, because we're looking at licensing rules, or we're looking at various different agencies that count them different ways. And what leaves us is a lot of frustration. But the way you start this conversation, if you want to know more about how do we fix this, you've got to communicate really and truly, like, what is the issue? Where are people getting stuck? What are the types of people getting stuck? And finding some alternatives for them. Because in many, many cases, we don't need more beds. People like to be treated at home. They want to be treated in the place where they don't lose their housing, they don't lose their jobs, they don't lose their families. And to do that, we need to get them in and out more quickly. And to do that, we've got to get people unstuck. So we're talking about that today. Join us again next time, where we're going to talk about the whole missing link of communication. See you guys then.